Hi, my name's Abigail Bennett, and I am doing my IRB proposal on iron deficient anemia, a supplementation regimen. So a little bit about iron. So it is essential, and most living organisms also need iron. It is found in the body as a component of hemoglobin. So hemoglobin is the substance in red blood cells that carries oxygen through the body. And it is also vital for many biochemical activities in the body, including electron transfer, oxygen sending, and transport. So I'm going to be focusing on iron deficient anemia in my population. This is a blood disorder that results when the body does not have enough iron to produce oxygen. So iron deficient anemia in women, it does affect more women than men. So 1 in 6 pregnant women will have IDA. More iron is needed during pregnancy to support the unborn baby's development. It can also be caused by bleeding. So up to 5% of women of childbearing age develop IDA due to heavy menstrual periods. Digestive system problems such as ulcers, colon polyps, and colon cancer can also cause heavy bleeding. Long-term use of over-the-counter pain medications, donating blood too often or not waiting a sufficient amount of time in between blood donations can cause excessive bleeding. And then uterine fibroids, which is non-cancerous growths in the uterus that can cause heavy bleeding. So all of these things mentioned contribute to heavy bleeding, which contributes to excess iron being out of the body. Also, not consuming a diet that includes a variety of iron-rich foods. So the body does absorb iron in animal-based foods such as meat, chicken, and fish 2 to 3 times more than the iron in plant-based foods. The body absorbs the iron from plant-based foods when you have them with vitamins, vitamin C such as oranges or tomatoes, things like that. Orange juice, if you eat that at your breakfast with your eggs, that's how you can, absorb some more iron. So also people with problems absorbing iron would be like somebody who has Crohn's disease or celiac disease or somebody with gastric bypass surgery. This would make it hard for them to absorb iron. And then there are complications if it's not treated with iron supplementation. Some of this can include in pregnant women, so developmental delay. Also a higher risk of complications both before and after birth if they don't have enough iron. It can lead to cognitive impairment in people, increased susceptibility to illnesses and infections. It can lead to organ damage and also heart problems due to the heart having to work harder to compensate for the lack of the oxygen in the red blood cells and the hemoglobin. So symptoms can include fatigue, lightheadedness, and shortness of breath. Also some odd cravings for things like dirt and ice, and paper is also common with IDA. But also they can have chest pain and restless leg syndrome, so it's not really too much fun. So my research question is going to be, is 65 milligrams of ferrous sulfate iron supplementation taken orally 1 to 3 times daily for up to 12 months effective in women with anemia for maintaining normal serum ferritin levels? So my hypotheses, my null hypothesis is that there is no significant effect of ferrous iron supplementation taken orally 1 to 3 times daily for 6 months in women with IDA for returning and maintaining serum iron to normal levels of 50 to 170. And then my alternative hypothesis is that there is an effect of ferrous iron supplementation taken orally 1 to 3 times daily for up to 6 months in women with IDA for returning and maintaining serum iron to normal levels of 50 to 170, sorry. So the purpose of this research is to determine which formulation is most appropriate. You do have a couple different formulations. So you have ferrous sulfate, which is what we're using in this study. There's also ferrous gluconate and also ferrous fumarate. And then dosage, so how many times do you want to take it? Frequencies, how many times, 1, 2, 3 times daily. Sometimes they say every other day, sometimes they say every 3 days. There's varying recommendations on how frequently to take it, but for the dosage, there's also varying recommendations. So sometimes some people recommend 15 to 20 milligrams of elemental iron daily. Some say 65 milligrams once a day. Some people say 65 milligrams 3 times a day. And there's even 325 milligrams that can be taken in one day. And the purpose of our research is also to determine the best delivery of the supplement. So you can either do oral or by IV. So it's, you know, we look at the literature to see which one's most effective. And then the influence of diet on maintaining adequate stores. So diets rich in iron, B vitamins, and vitamin C are all important for IDA. So informing the participants of these items, or the food items that contain these nutrients, will help them to keep their iron stores at adequate levels. So the current literature, so according to Arbach, malnutrition, malabsorption, iron-poor diets, and comorbid conditions impede iron utilization and lead to ID, so iron deficiency, affecting 9 to 15% of menstruating women, which is quite a bit. And then according to Ray, no formulation has been shown to be superior and less toxic to the GI system than ferrous sulfate, except for time-release and enteric-coated formulations. And then 100 milligrams of oral iron given only with water, 80 milligrams AA, which is ascorbic acid, so vitamin C, increased iron absorption by 30% and proved to be an effective regimen for iron supplementation. And then to continue the literature review, so Santiago stated that in an analysis of 5 randomized trials to compare oral and IR, which is intravenous iron replacement therapy for iron deficiency anemia, hemoglobin levels typically responded quickly to oral iron therapy, but repletion of iron stores and normalization of serum ferritin levels may require longer adherence to supplementation. This can be anywhere from 3 to 6 months of treatment. So this is based off this study. This is actually why I chose my study to be 6 months, as opposed to initially it was just a 12-week study. Pino Rosas did say that ferrous sulfate remains the standard treatment of iron deficiency, irrespective of the indication, given their good bioavailability, efficacy, and acceptable tolerability in many clinical studies. Most clinical studies do recommend ferrous sulfate, which is why I ended up recommending that. And then Occam did state that the idea behind the intermittent supplementation is related to the concept that exposing intestinal cells to supplemental iron less frequently may improve efficiency of absorption, since the cells are not blocked by large amounts of iron that occur with daily intake. So you can see in the literature, some people are in favor of daily, some people are in favor of intermittent dosaging. So it's all over the place. A little bit about the importance. So the significance of this study is to really determine the best administration of iron supplements to support women with IDA in maintaining and achieving those levels that are normal for iron. And we want this to also be long-term. There is compelling research that provides insight into oral routes and intravenous routes as options for administration, while still not providing clarification on the most superior form of administration, formulation, dosage, and timing. So future research can provide an enormous impact on supplementation recommendations for women with IDA, and also get into the specifics of the administration methods, formulations, dosage, and timing. So contribution to the field. Using the literature review, there has not been a good, sufficient, one-size-fits-all approach to treating iron deficient anemia. So this is like many other medications and clinical diagnoses in the medical field. So the goal of the study is to find the most widely accepted form of iron supplementation that provides appropriate rises in specific iron indicators, just like with other medications. They only put the ones on the markets that, are most widely accepted, the ones with the least amount of side effects, pretty much. Determining the most appropriate dosage, formulation, administration routes, and time of consumption is necessary to establish more specific recommendations. There is no research out there at this time that specifies all 4 factors, that I just said, in regard to the supplementation. So that's why, it is very exciting for the field. So subject recruitment. I'm doing women 18 to 65, above 65. Anemia can accompany other things that we don't want to get into just quite yet. So we're kind of just looking at iron deficient anemia, and that's it. They can be of menstruating age, menopausal, and postmenopausal, so anybody. They can also be pregnant. And then the women must meet the iron markers that represent IDA. So this is, of course, after we've gathered their consent and they've agreed to participate, but we're going to test their hemoglobin, serum ferritin, hematocrit, and then mean corpuscular volume. So we test a few other things, but I didn't include them here. But these are the big four we're going to be looking at. So a hemoglobin of 12 to 16 grams per deciliter is normal. So anyone with 12 or less will take. Serum ferritin of 13 to 150 nanograms per milliliter is normal, but for this study, I'm going to take any woman with serum ferritin of 30 or less. And then hematocrit of 42 to 48% is a normal range, so 41 or below will be qualified to be in the study. And then MCV of 80 to 100 femtoliters is normal range, and for me it'll be anybody below 80, so they need to meet not just one but all of these markers in order to be in the study. So exclusion criteria, so they cannot be taking any oral iron supplement right now because we want to see what this supplement alone can do with no interactions of any other ones. No vitamin or mineral supplements in the last 2 weeks. That's everything including vitamin C, a multivitamin, nothing. So they will have to, once they consent to the study before it begins, they will have to stop whatever regimen they're on for any other, vitamins or minerals, just to make sure we're not affecting iron. No blood transfusions, blood donations, or significant blood loss over the last 4 months. Women with thyroid disease, autoimmune illnesses, chronic illnesses like HIV, tuberculosis, etc. will not be included. And then conditions that affect iron absorption like IBS, cancer, congestive cardiac failure, chronic liver failure, other things like that, they will not be included. And then pregnant women who have any other type of anemia will not be included. Only women with iron deficient anemia can participate. Recruitment and methods of study. So the subjects will be contacted at their primary care physician group, which is the Millennium Physician Group of Florida, and we chose this one because they have over 550 offices, making them the biggest physician group in the state of Florida. So we will contact the women at either their primary care physician or their OBGYN. Once we get consent, we'll do the initial screening for IDA, and the initial screening will be the biochemical markers. So when they're there, we'll go ahead and have all those things done. And then 5,000 to 7,000 women outreach is the goal, and only about 30% will be eligible for the study is what we're thinking. So that's going to be about 1,500 women who will be included in the study. No control group. So I did this because all of the data that exists already on iron supplementation for IDA does report an increase in iron indices no matter what amount of iron. Even if it's the smallest amount, the largest amount, any bit of added iron contributes, to the iron levels. So we already know we don't need to keep a control group at a certain amount. Consent forms will be filled out via QR codes as well as the initial surveys to determine symptoms, diet, menstruation flow, and so many other factors that we want to know about. The QR codes, what will happen is they'll be printed on pieces of paper, put at the front where you sign in at the doctor's office. It'll kind of give a brief overview of what we're doing. And then if they do the QR code, they go ahead and consent. And then once they consent, they will fill out the initial surveys, and then we will go ahead and get blood tests done. So the data will be saved to a Google Drive folder that participants will have access to once the study is complete. And then again, it is 65 milligrams of oral ferrous sulfate administered 1 to 3 times. And we're going to look at the data comparing the 1, 2, and 3 groups because some women might have to have just 1 a day, some 2, some 3, depending on how well they tolerate it and their GI symptoms. Also, we will include 1 mixed group, so that means the women that they could have bounced around from 3 to 1, 1 to 2, whatever. They weren't just taking 3 doses of it daily the entire time. So data analysis. So online surveys will be given to assess emotional, social, and economic barriers that affect adherence to the regimen. We will also use calorimetric iron analyzers to assess their iron indices, quantitative and qualitative data. So this will be, anthropometric data, their iron indices, stuff like that will be our quantitative, and then the qualitative is going to be the more emotional, social, and economic barriers and their answers to those questions as our data. We're going to use the RM ANOVA, so the repeated measures analysis of variance, to repeatedly measure outcomes before and after the intervention is implemented. This test best fits this study as it is ideal for comparing groups made up of the same people, again, women with IDA. Iron indices in the blood will be assessed before the intervention, during, and after the intervention has been completed. The findings of this statistical test indicate whether the mean scores on the outcome differed across occasions of measurement within the same group. Also, we will be taking their test once a month, so at the beginning and at the end of the entire study. We'll take iron tests, so looking at their serum, ferritin, hematocrit, stuff like that. And then we will take it monthly just to see how their bodies are reacting to the iron regimen. So this will not likely suffice for the entirety of this study, so we've also decided to include an HLM, which is the hierarchical linear models, which this test is a complementary data analytic method to generate findings that show the pattern of change in the outcome for individual participants and the percentage of participants who demonstrated the expected improvement. So I think this will be great for this study, as it does, it's going to describe the direction and magnitude of the change for each participant and emphasize that change in a continuous process observed over time in our participants. So we will aggregate the data when we report it. This will allow the data from all participants to be compiled into a summary that identifies the key findings and points of the study. This will include most experienced adverse side effects of the oral iron supplementation regimen, as well as iron indices that were able to fall within normal ranges once on the regimen. So in conclusion, determining the factors of dosage, formulation, and frequency will help physicians and women make more informed decisions regarding their iron intake and allow their iron levels to reach healthy ranges. So we need to address factors that can affect how well the body absorbs iron and potential side effects. And then we do have a few limitations of this study. So the sample size is only women in Florida, which is not going to be representative of the whole United States, let alone the entire world, when iron deficient anemia is a blood disorder that affects a lot of people worldwide. And then dietary factors and habits are not controlled. So this can affect iron absorption, and in the study, we don't look at what they eat. We don't tell them what to eat. All we do is simply observe it, and we educate them on iron-rich foods and how to get the most out of your meals for absorbing iron, but we will not control what iron-rich foods they eat and don't eat. And then time constraints. So the goal is to complete this in 12 months in the future. So to do a 12-month study rather than 6 months. 6 months is a little short, I feel like, to really see long-term effects with the diet factors included more into that. All right, well, thank you so much for coming to my presentation.